Good evening, everyone, and welcome to the AEMT Transition Protocol Update for 2020, course number 23214, Part 1. This module will cover the general information related to the 2020 AEMT Protocol Update. We'll go over some of the information that's covered in this. That will include weights, measures, and a general overview related to medications. This module is presented to you by Rick Pearson. I'm the Lancaster EMS Director of Education, along with the permission of Dr. Michael Rehart, who has previewed and authorized this hybrid format. Due to the COVID-19 restrictions, we will be partaking in a hybrid learning of this information. Should you have any questions, comments, or concerns, or problems along with these modules, any of the quizzes, or the learning management system, the Blackboard course site that you're in, please send me an email at richard_pearson@lemsa.com, and I'll return your email, and or if you provide me a cell phone number within a relatively short time after you get a hold of me. So with this presentation was initially provided to us by the Pennsylvania Bureau of EMS, thanks to the assistance of EMS West, which is the regional council that covers a large portion of the western side of the state Commonwealth of Pennsylvania. So thank them for their time in that. So just to review, the purpose of this module and this course is to review, update, and educate current and future AEMTs into the 2020 ALS protocols. Also review the patient conditions in which an ALS provider of the paramedic level and above should be requested by an AEMT or a IALS unit. And again, depending on where you're located in the Commonwealth, if you are watching this, it's either AEMT unit or an intermediate ALS unit. And then just to make sure that all of this education, learning, and compliance is online, all of this information has been updated with the 2019 National Scope of Practice, the 2020 ILS protocols, as well as the integration with the new 2020 Pennsylvania Bureau Scope of Practice. Along with this information that you'll find here in the LMS, as well as some other places I provided resources for, please make sure that you begin reviewing appendices B, C, D, as well as the adult and pediatric conversion chart when it looks at weight to medications. The Bureau of EMS is working hard to make sure everyone is to have reference pieces of material available when it comes to medication delivery and choosing the appropriate amount. So please make sure that you have access to those conversion tables. I will reference them in this module, as well as you can look them up online. You could download them as PDFs to your smartphone, or if you are familiar enough with several of the larger health systems, they do have apps which will allow you to use an online version of these protocols. All right, so why the change? To better provide timely and efficient care and treatment to our patients that we see, to better utilize AEMTs within their skill and scope of practice, which is again our AEMTs and this new certification level in the scope of practice lies naturally in between the EMT and the paramedic. But unfortunately, there are a lot of EMTs as well as paramedics and PHRNs, as well as hospital individuals who work in the ERs don't understand at this point what an AEMT's capabilities are. So this module is open to anyone who wishes to take it. It is mandatory for the AEMTs, but anybody else wishing to learn what the scope of practice of an AEMT is more than welcome to take this. This help to the changes to enhance the patient care in all geographic areas, especially when we get to rural areas where full coverage of ALS care may not be available due to call volume, access to paramedics or PHRNs in that area. Also, to better prepare for the future of EMS in the future while looking at a three-tiered response system, BLS, intermediate ALS, and ALS, because we're no longer looking at it just as an ALS or BLS system. We're looking with integrated 911 and increasing those capacities. Individuals who are allowed to present this material, one are your agency medical directors or any EMS instructor that are above the AEMT level that have been designated by the agency, in this case Lancaster EMS, or a regional medical director. And Dr. Rehart has been kind enough to allow us to get this up and out and put into this hybrid format for ease of access and learning. So please remember, please have your 2020 protocols available for review. There's the website there that you can go to and check up to date protocols, scope of practices, legislative changes that are available to you. This one is the updated one. As I said earlier, you can find them in the LMS system that you're accessing this module through, app systems or anything else like that you may have. We're going to go have 3 general online reviews with 3 separate modules. This one that you're currently listening to and watching are the general drug review module, and then the next one we're going to review of indications for ALS as well above the AEMT level, and we're going to review protocols and update you in pretty much anything you need. Please realize that this is a hybrid format. You'll do the didactic portion here along with some quizzing to check to see how you are doing and moving along, but then at a later date we will have to have classroom time to go over skills and to make sure that you have mastered the physical aspects of this update. So what's new in 2020? Well, we have 2 new protocols. We've increased from a total of 13 in 2019 up to a total of 23 for 2020, and these 10 new protocols are all listed here. What are the indications for further upgrade to ALS, cardiac arrest, traumatic, and hypothermia? We're going to look at multi-system trauma or shock. We're going to have a protocol now for musculoskeletal trauma, crush syndrome, burns, non-traumatic pain management, patients specifically suffering from nausea and vomiting, and postpartum hemorrhage. So these are the 10 new protocols that we will go into depth along the way here. We're also going to be looking at the appendix, as I alluded to earlier, Appendix B, which is a med dosing chart, Appendix C, which is going to be a med dosing chart, but of common oral medications. And then finally in Appendix D, we're going to look at the pediatric weight conversion chart. So here we see Appendix B, where on the far left side here, if you look on the left side, my apologies, we have the age in years, the age and average weight, and notice that we have converted everything over to kilograms. Now please remember 1 kilogram equals 2.2 pounds. So you need to have a working knowledge of how that works, but you're able to utilize this chart to be able to estimate that. But please realize our brains tend to work in pounds. So you need to be able to accurately convert an individual's pounds to kilograms, and we were to round up or round down, but please note that the average here, looking at age, 10 kilogram to 15 kilogram, so you're going to have to choose which one to go with. And then down as we go along, notice the crystalloid fluid, your IOs, IVs, an individual who is 1 to 2 years of age, average weight 10 kilos, which is 22 pounds, would get 200 mLs of a crystalloid doing a fluid challenge. All right. Diphenhydramine, your dextrose, your epi, your IM epi, which is 1 milligram per milliliter, versus your cardiac epi, which is designated as 0.1 milligrams per milliliter. Those are given to you in milliliters, not in milligrams. So you need to be able to make that conversion as well. Ondansetron, which is your Zofran, that comes in 2 milligram per milliliter vials. The ones that we have and seen the most currently are 4 milligram vials, so they're 2 milliliters. Again, we're giving it based on our average weight, average age, and then we are giving it in volume, milliliters. All right. When we get to glucagon and Narcan, please realize that that is being given in milligrams. So you have to be mindful of what your unit of measure is. When we get down to Appendix C for the oral, again, notice there is some transition here where we have our reported weight in pounds of 25 to 35, 36 to 47. Please realize that you're going to have to do that mental math. And again, the conversion is 1 kilogram equals 2.2 pounds. And here you can see the Benadryl, the ibuprofen, and the Tylenol. And again, these are the charts that you should have access in your protocols. And then here we have the Appendix D, which allows us to go in and look at our pediatric weight conversion. Pounds is in the dark font, whereas kilograms is in the blue font. And as you can see here, we start moving from pounds to kilograms. And again, 2.2 pounds equals 1 kilogram. Should you have any questions about how the conversion works, there are Google Khan Academies that are available for you for follow-up. But if you'd certainly like some personal assistance, please feel free to send me an email. Other ways that we can look to figure out the weight of a child in estimation are weight estimation tapes. This one particular is called a Broslow tape, where we take the Broslow tape and lay it next to our child, putting the red side closest to the crown of the child's head, and then going to the plantar portion of the soles of their feet. And at that point, they will fall into a range. And that range there usually will coincide with any of these drugs as well, as you will find them listed there. But that is a good way to figure out and estimate a child's overall weight. Some other things starting of ALS skills. There are several new protocols now which will allow us to start IVs. They've been added to these following protocols: the cardiac arrest, traumatic, as well as the hypothermia, multi-system trauma, trauma shock, multiskeletal, musculoskeletal trauma, Crest syndrome, burns, and postpartum hemorrhage. Those are the new protocols which now allow AEMTs to initiate a IV. Couple updates when it comes to safe medication administration and the new meds that have been added to your protocols. General notification here. Please realize this, that as a healthcare provider, you are sworn to a lifelong learning. When new things come up, it is your responsibility to maintain a level of competency, and that holds true even into the new medications that are being presented here. So in this general concept, please realize, and I will read this word for word, that EMS providers are expected to know the contraindications for each medication and are expected to assess patients for allergies when possible to give any medication to any medication that is given. EMS providers should not administer medications to a patient when that medication is contraindicated in those or that situation. Please realize that this presentation does not cover all contraindications. Therefore, it is your responsibility as a healthcare provider to know what they are. Your due diligence is expected as well as demanded, that you know what to give before you give it and how you give it. Just because we can doesn't mean we should, so please realize that. So some of the new meds that you're going to be expected to know and be able to give based on your services adoption of these new protocols. Epinephrine for cardiac arrest, IV or I only. Now, please note, you're going to have two different concentrations of epinephrine available to you and various ways in which to administer. You have to be the expert in how to be able to do that efficiently, correctly, and safely. So we're going to see a couple different versions of epinephrine, but the epi for cardiac arrest, IVIO only. We're also going to have the ondansetron, the Zofran for nausea and vomiting. All right, and if your medical director does approve, you will have the authorization to administer acetaminophen or ibuprofen for non-trauma pain. You also have access to nebulized and or racemic epinephrine. This will be utilized for nebulization for pediatric upper airway compromise. You'll also be able to give diphenhydramine or Benadryl for allergic reactions. And if your service chooses to do so, you will be able to administer ketorolac or Toradol. And even though this is not in the protocols officially, it is in the process of being written into it. But if you do choose to give Toradol at this point, it will only be under medical command order, not above the line, and you will not be able to give it with protocol. You have to call for it. All right. All right, so let's get into looking at some of these new drugs that you're going to be able to administer in this. So the first one is going to be epinephrine for cardiac arrest. This concentration here that you can see is 0.1 milligram per milliliter. And please note that your epinephrine here, your cardiac epi, comes in 10 milliliter vials. These are commonly referred to as amps or pre-filled, but please note that they do have specific dosages which require to be documented in your EPCR. But this epinephrine usually comes in brown boxes of this nature. They are pre-filled. You take them and you crank them open. But please note there is, in the past year or two, there has been a transition into the nomenclature that we discuss when we talk about their concentration. In the old nomenclature, cardiac epi used to be known as 1 to 10,000 solution. Now this new nomenclature has been changed, as we said earlier, to the 0.1 milligrams per milliliter. All right. Please note that these drugs do expire, and somewhere on the box you will find that they do have a expiration date. This box that I took a picture of expires May 1 of 2021, meaning it needs to be either utilized, rotated out, or disposed of after that date, May 1st of 2021. But just a refresher, classification is a sympathomimetic. It's an adrenic agent. It's an inotrope, which means it causes increase in heart rate as well as left ventricle to beat harder. Okay, this also has another name. This, if you read some literature that may come from Europe or the UK in that manner, you may see this be called adrenaline. All right, the mechanism of action is it binds strongly with both alpha and beta receptors within the heart. As I said earlier, it increases our heart rate, the automaticity of the electrical signal from the SA node, increases cardiac contractile force, increases the myocardial electrical activity, increases our systemic vascular resistance, which causes an increase in blood pressure as well as bronchodilation. Indications for this are going to be bronchial asthma, exacerbation of COPD, allergic reactions, as well as anaphylaxis, restoration of cardiac activity in cardiac arrest. Now, these are general indications for epinephrine. The box that we are seeing here is the cardiac arrest only dosing. You cannot give this concentration for bronchial asthma, exacerbation of COPD, allergic reactions, or anaphylaxis. This concentration, 0.1 milligram per ml, can only be utilized in the restoration of cardiac activity in cardiac arrest. And when we do give it in cardiac arrest, we are giving 1 milligram. We're giving a 1 milligram of the drug that is diluted in 10 milliliters volume of generally normal saline. All right. Now, the second type of concentration of epinephrine that we're going to be utilizing is going to be for intramuscular or nebulizer use. As I said earlier, the cardiac epi, the 0.1 milligram per milliliter, is only available to be utilized in the restoration of cardiac activity in cardiac arrest. The IM version, the 1 milligram, is able to be utilized for asthma, exacerbation of COPD, the allergic reactions, and anaphylaxis. Primarily in your protocols, you will be utilizing it for the allergic reaction and anaphylaxis. But this drug, the way this is packaged, is it is packaged in a couple different ways. One is in glass ampules. Here you can see epinephrine injection, 1 milligram per milliliter. This is the same thing in glass ampule. Here, this is a box of 10 of these. And then finally, we have a 30 ml reusable vial of 1 to 1,000. Most of the time, and most prolific is, you will see these glass ampules. Now, along with your glass ampules in this, or the 1 to 1,000 solution, depending on how it is available to you, if we choose to use it via nebulizer, all right, we need to have also availability of sodium chloride to help dilute it and nebulize it. So we will need also some type of isotonic crystalloid, in this case normal saline, either a normal saline flush, or we have these, you may see these iFlush kits. Now please note, epinephrine, the 1 milligram ampules that you see here have also undergone a nomenclature change. The old version used to be 1 to 1,000. Here you can see I was able to capture this 1 to 1,000 on it, but now the new nomenclature again is 1 milligram per 1 ml. All right. 1 milligram ml. So just please note here, I just marked down here that the normal IM dose for an adult patient is 0.3 milligrams, which equals to 0.3 milliliters. This is very concentrated. Whereas in the nebulizer dose, we will be giving 1 milligram, and we will be adding 4 mLs of normal saline into the nebulizer chamber. All right, with that. Now, the one thing to remember, if you've never had the opportunity to open one of these glass ampules, is the possibility of, one, cutting yourself, but also having shards of glass, small slivers, fall into the liquid medication. So with this, you're going to have to, if you've never utilized this before, we'll introduce you to it in the manuals, into the psychomotor sessions. We'll introduce you into filter needles. Now, these are just real quick pictures of a 5 micron filter blunt fill needle here. Okay, they look like this, and this is what it looks like down the barrel. There's a small filter that will filter anything 5 microns and larger out when you draw this in. That way, if you put this on top, put your blunt filter needle on top of this, crack this top right here, insert this into here, and draw out the appropriate amount of drug that you need, it would then be drawn up into this, and any shards of glass would be caught on the other side of this filter. Now, this does require you, once you are ready to give either the shot or put this into your nebulizer, you're going to end up having to remove this filter needle and put on either another filter needle or just a regular needle. IM administration locations, just to give you a refresher here, either deltoid, either glute, or either left or right thigh. And again, when we look back, we do not use a filter needle for this. We will need an IM needle for that. But again, deltoid versus the glute versus the midline quads right down here. All right. Preferred location is in the left or right midline lateral quadriceps, your thighs. It is the easiest, and on an adult patient and even a pediatric patient, the largest muscle group to get to. Please remember, using an antiseptic technique with alcohol, rub the area clean, give your injection, then swiftly pull it out and then rub that area as much as you can, because that area with IM, you do need to get a lot of blood to that area to help that medication be absorbed into the rest of the body, and that is accelerated by vigorous rubbing and stimulation of the injection site. So in general, just to review some of the things that need to be documented in your PCR when giving any medication, not just an IM, but when you give a medication, you need to put down your patient's best weight, or the best estimate of that patient's weight. Again, pounds or kilograms, either or, but please make sure you do document somewhere along the way within your PCR. Also, any dosages of any meds that are administered, not just epinephrine, but make sure when you do give a medication, not only do you give them the type of medication that was administered, the route, the injection site, and the time of the administration, not to mention the overall dose, as well as please don't forget to pre and post vitals at the same time. All right. If you're contacting medical command, that's what CMC stands for. If you're contacting medical command at any time, please make sure that you document not only the time, but also the name of the medical command physician, as well as any orders that he or she advised you to do, and make sure that you always document that you repeated those to the command physician to make sure that there's a clear line of medical authorization. Document if you draw any blood glucose levels. Please remember the units that go along with blood glucose levels is milligrams per deciliter. It's just not 132 or 40. We need to have an mg per dl in there and lead it with, a BGL or blood glucose level of 32 milligrams per deciliter. Was measured. Also, any chance you get in any documentation, please remember your pulse ox. If you are using an advanced airway, your end tidal CO2 waveform capnography, as well as having that uploaded into any PCR software as of your waveform capnography needs to be uploaded into your PCR. What is your heart rate? What is your blood pressure? As well as respiratory rate every 5 minutes, and that's especially true after the administration of epinephrine. So a full reassessment of vital signs every 5 minutes with the administration of epi. All right. Even if it's, they're in cardiac arrest and you feel for a pulse and it's 0, that document it that you did it. And then please remember that during transport of your patient, never place them in the prone position. They are either in a full supine position, are they in a Trendelenburg, or are they in a left lateral, are they in a right lateral, are they in a modified recumbent with Trendelenburg, knees lifted, something like that. Be very, very open about how you're transporting that patient in the PCR. And if they're really don't know what to say, just say patient was placed on the bed in a modified supine position of comfort positioning. Some equipment consideration when giving an intramuscular injection or using a syringe along with needles. Please realize that the needles do have sizes, not only length consideration, but also diameter consideration. And here you can see a generic 10 cc syringe. It's listed as a 10 cc, but there is 2 to 3 cc's more, or mLs, my apologies, that shows my age, milliliters of fluid can fit into this syringe. And then we have our intramuscular needles, IM needles, or are also known as hypodermic needles. Now these are safety needles that after you administer the medication, you're able to slide this this plastic portion up to cover to sheath the sharp needle, but we don't want to get we want to take care of this and be kind to these needles before and after we administer any medication, because again, we don't want to accidentally give ourselves a needle stick. But as you can see here, this is an 18 gauge needle IM. This is a 21 gauge IM needle. You can see here on the packaging, 18 gauge by 1.5 inches long. That is the distance from the end of the hub to the tip of the needle. Here we also have a 21 gauge, smaller diameter, 1.5 inches still as long. And then here we get to a 23 gauge, 1 inch. Notice the diameter, not only does the diameter get different, change size, but also the length changes size. Please note that IVs and hypodermic needles utilize the American wire gauge, meaning the smaller digit number, the larger the diameter. So an 18 gauge is larger than a 23 gauge. So please be aware of that when you do that. And this needs to be documented as well in your PCR, because if someone has wayward IM injection points and somebody questions it, we have to be able to go back to our PCR and say that AEMT XYZ injected into the left deltoid utilizing an 18 gauge needle, a amount of 0.3 milligrams of epinephrine. So again, 18 gauge, 21 gauge, and 23 gauge. They're various sizes, just to let you know. All right. Now let's look at the administration of nebulized epinephrine. The protocol states that we're allowed to utilize, we can utilize racemic or epinephrine in the 1 milligram per milliliter concentration for that. There's not many services I'm aware of right now that is carrying racemic epi. We carry this concentration of epi, and it's just as effective. But the equipment that we're going to need to be able to nebulize this obviously will be the drug, the 1 milligram per ml ampule. We're going to need a blunt film needle as well as another needle to go along with it. You can utilize one of these hypodermics as well to inject the fluid as we draw it out and out into our nebulized chamber. All right, and then along with 4 mLs of normal saline into our nebulized chamber. Okay, now just for a little learning thing, what is a micron when we talk about micron filters? Well, the size of a micron is interesting, and it's an abbreviated term for micrometer, or a millionth of a meter, which is about 0.00004 inches. So if we compare that, a human red blood cell, which I have down here, this is electron microscope, okay, a human red blood cell is about 5 microns across, so it should let that through there. But just in comparison, a human hair, okay, one hair on our head is about 75 microns across. Okay, and just to give you a little general idea, bacteria can be between about 0.2 of a microns and 3 microns in size. Okay, and just for a little comparison, when we look at the human hair and a fiber optic cable at 10 microns right there, just to give you a little idea of what that is. Some other drugs that we're going to see in either a vial, an IV dosage, or an oral dosage is Zofran or ondansetron. Ondansetron is classified as an antiemetic, okay, selective 5-HT3 receptor agonist, and our indications for this is individuals with profound nausea and vomiting. Now, please realize that with these routes, we can give this intramuscular, we can give it oral dissolving tablet, or slow IV. In your protocol, I believe it's only slow IV or oral dissolving tablet. We'll go over that later. You give it, and when you give it slow, you have to give it over 2 to 5 minutes. And again, the dosage is going to be anywhere between 0 to 4 milligrams, especially when we look at the pediatrics with that. But please realize if someone is actively vomiting on you, giving an oral tablet, a disintegrating oral tablet underneath the tongue or something like that, may be a little difficult to get in until they're no longer vomiting. Next drug we're going to look at is diphenhydramine, also known as Benadryl, and there are 2 types. One is the IV IO route, or the oral route. It is classified as an antihistamine. It binds and blocks H1 histamine receptors. The indications are in anaphylactic reactions or mild or moderate reactions as they're defined in your protocols. The routes are going to be IV or IVIO or oral. And your dosing is going to be weight related. We'll talk about those later. Anywhere between 12.5 to 50 milligrams. All right, and here you can see the IV is a 1 ml vial with 50 milligrams in it. So 50 milligrams per ml. We have 1 ml, that's 50 mgs. Okay, whereas Benadryl typically is 12.5 milligrams per 5 mLs. So we'll talk about that a little bit later in the next week. Next drug, if your medical command authorizes and you're permitted to carry it, is going to be ketorolac, also known as Toradol. This is an NSAID. It's same classification as aspirin and or ibuprofen, non-steroid anti-inflammatory drug that's used for treating pain and inflammation. And its mechanism of action is going to be inhibiting the cyclooxygenase, the COX enzymes. Okay, its indications are for short-term, usually up to 5 days in adults, management of moderate to severe acute pain that requires analgesia at the opioid level, and is only a continuation treatment following IM or IM dosing. All right, the total combined duration of use of Toradol, oral as well as IV, should not exceed 5 days. So if you're going to give this, you're going to give dosages 15 milligrams via IV or IO, and that's going to be, if you have to give it IM, that'll be 30 milligrams. And when we look at pediatrics, please realize that it is weight dependent, so 0.5 milligrams per kilogram via IV, IO, or IM, with a maximum dosing of 15 milligrams via IV or IO, or 30 via IM. Nebulized treatments that we're able to give, we can give albuterol, which is a standalone drug. Its classification is a bronchodilator, beta sympathetic agonist. Mechanism of action, it stimulates beta 2 adrenic receptors that result in the overall smooth muscle relaxation of the bronchial muscles. Its indications are for asthma, bronchitis with bronchospasm, COPD, or allergic reactions. Typically, we will utilize albuterol when we hear expiratory wheezing. Now with albuterol, we use 1 vial, 2.5 milligram and 3 mLs into our nebulizer, and then we turn on our nebulizer anywhere between 6 to 10 liters per minute of oxygen flow, and there's that range in there based on atmospheric pressures, all that other stuff. Please remember the higher the nebulizing the oxygen to get the nebulizer to go, the quicker the drug is going to be utilized, as well as dependent upon how fast your patient is breathing. All right, the other drug is what is referred to as a duoneb, which is a formulation of albuterol and ipratropium. We refer to those as duonebs. In this picture here, you can see it is differentiated from an albuterol package by the albuterol just has the blue area, whereas the duoneb has the purple with the drug name. Now this, again, ipratropium bromide is 0.5 milligrams. Albuterol is 3 milligrams, and that is all dissolved in 3 milliliters of fluid. That again goes into a nebulizer and oxygen flow at 6 to 10 liters per minute. Now, this also is a bronchodilator. There's the albuterol, but the ipratropium is what is known as an anticholinergic or a parasympathetic. Okay, and basically what this does is this helps to dry up any mucus that might be in the system. Typically, when we see individuals that have a bronchitis, a productive cough, they have maybe some wheezing, and with some wet sounding lung sounds, we can go ahead and give the duoneb to help clear those up as well. But your protocols you will find later on will allow you to give either or. Next drug that's been added has been acetaminophen. Here you can see a quick picture of one. They come in 10.15 ml containers, one patient use. This is considered an analgesic. And the way that it works on the hypothalamus to produce antipyresis, reducing the fever. Okay, it may also work peripherally to block pain. Also inhibits prostaglandin synthesis in your central nervous system. Its indications are going to be analgesia and fever. The routes for this are going to be oral. This is an oral suspension of 325 milligrams per 10.15 ml. And our dosing for this is going to be anywhere between 160 milligrams to 650 milligrams. Our next drug here is ibuprofen, children's ibuprofen to be exact. It's an oral suspension of 100 milligrams in 5 mLs. Okay, it's classified as an NSAID. We saw that with the Toradol, and this is used for treating pain, fever, and inflammation. Okay, its indications again are analgesia and fever. This route here is oral, and our dosing based on our dosing charts is going to be between 100 to 400 milligrams per dose. Now, just so that you are aware, some of these drugs are above and beyond what the state requires for the required drug list for ILS vehicles. So if you end up going on an ILS vehicle or another service that may not have an expanded scope, or they choose not to do certain things that are permitted by your medical director, just so that you know, these are the minimum drugs that are required to have on an ILS vehicle for licensure. They include albuterol, aspirin, dextrose, your epinephrine, all right, your 1 milligram per milliliter concentration, glucagon, Narcan, nitroglycerin, sublingual, a normal saline solution, your isotonic solution, and oxygen. But again, they may carry additional meds that are allowed and approved for by your medical director. And just for a little review to let you know, these are the list of the currently approved AEMT medications as of May 2020. We have acetaminophen, we have activated charcoal, albuterol, which we talked about, the Duoneb, the albuterol with the ipratropium, aspirin, bronchodilators. If you end up having a listing for a meter dose inhaler, you may utilize those. As we talked about already, dextrose, diphenhydramine, the various concentrations of epinephrine, okay, 1 milligram per ml, 0.1 milligram per milliliter, as well as if your IALS service has asked for licensure on the Epi auto injectors, you could certainly be carrying those as well. Glucagon, oral glucose, ibuprofen, ketorolac, Narcan, not otherwise listed above, okay, Narcan, IN or auto injector, a nerve agent, antidote kit that could include atropine, praloxamine, or diazepam, your various nitros, nitrous oxide if you so choose to, your isotonic solution of normal saline, your Zofran, your oxygen. All right. So we've run through that pretty quick. Please review all of your protocols and your general information with relation to that. So now please proceed to the quiz that is titled related to part 1. You must pass this 10-question quiz with 80% or greater, and that is required to continue on to part 2. Please realize and don't worry too much. You have unlimited attempts at that quiz. So this now concludes part 1 of the AEMT 2020 protocol update. Should you have any questions, concerns, please feel free to fast forward, rewind to any part that you need over, or if you have specific questions that I did not answer in this presentation, please feel free to email me at richard_pearson@lemsa.com. Thank you and have a good night.